Good afternoon, everyone. My name is Dr. Surbhi, Junior Resident in the Department of Psychiatry, and I will be talking on the I will be speaking on the seminar on the topic of neuropsychiatric aspects of vitamin deficiency. So today we'll be covering this topic under these headings. First of all, a little bit introduction about what are vitamins, then the action of mechanism with respect to the neuropsychiatric physiology and neuropsychiatric pathology, then some special populations who are at a risk of inflicting neuropsychiatric illness due to vitamin deficiency or vice versa, and common neuropsychiatric manifestations which are quite common amongst all the vitamin deficiencies. And then we will be talking about some specific neuropsychiatric manifestations of specific vitamin deficiencies. Then finally, we will be talking about the management, and in the end, I'll be summarizing and followed by references. Introduction. Vitamin deficiencies can significantly impact the neuropsychiatric system, leading to various cognitive, emotional, and neurological symptoms. So there are two types of vitamins which are known to us, and first is the fat-soluble vitamin and then the water-soluble. It is actually based upon it is quite suggestive from the name itself that it is based on this solubility in the human body. So fat-soluble vitamins are the vitamin A, D, E, and K, and water-soluble are the vitamin B complex and vitamin C. Now, another significance about this fat-soluble and water-soluble is that the fat-soluble vitamin deficiencies are something which are seen over the year. So, if the patient or the person has been falling short of the dietary intake over years, then is when the fat-soluble vitamin deficiencies manifest. And as far as water-soluble deficiencies are concerned, they manifest both ways. They can also manifest acutely and chronically. Now, action of mechanism. Vitamins, they display innumerable action of mechanisms basically. But as far as the neurophysiology is concerned or neuropsychiatric aspect is concerned, these are the four subheadings under which the action of mechanism of the vitamins can be studied. So first is the neurotransmitter synthesis. So vitamins like vitamin B6 and B12, they are essential for synthesizing neurotransmitters like serotonin and dopamine. And it is said that this is because of this impact of B6 and B12 that leads to the mood symptoms or the psychotic symptoms. Myelin formation, vitamins such as B12 and E, they are crucial for maintaining the myelin sheath around the nerves. And the vitamin B12 is one of the most studied vitamin as far as neurology is concerned because of this impact of it. Then coming to the antipsychotic protection, vitamin C and E, they act as antioxidant protection. Vitamin C and E, they act as antioxidants, protecting the neurons from oxidative stress. Vitamin A also has said to have the antioxidant effect. Along with that, homocysteine regulation. Now, deficiencies in B6, B12 and folate, they can lead to elevated homocysteine levels, which increases the neuropsychiatric risk. This is something which is still a very hot topic, and more researches are being done on the homocysteine level and the impact of homocysteine on the whole pathophysiology of neuropsychiatric illnesses. Now, these are the special population which are at risk, especially the elderly who are at risk, and the reason being because obviously they are dependent, and the same goes for children as well, because they are very dependent population. They have to depend on their caregivers for nutrition, and somewhere because majorly elderlies are left alone, they are not taken care of, so therefore they are at a very high risk of having the neuropsychiatric manifestations of vitamin deficiencies. Children, because they go through growth spurt, and as our country is still a second world country, so because of the ill nutrition distribution amongst the population and amongst the socio-economic groups, so children are still more prone to the aspects. Then alcohol users, which is also very widely studied amongst all of them. Then psychiatric illnesses are also people who are suffering from psychiatric illnesses are also come under the special population, because again these people are also somewhere dependent on the caregivers, and somewhere because of lack of insight, and even with depressive patients who have insight but because of lack of appetite, they are also prone to this. And chronic illnesses can be anything, people who are suffering, ranging from infections to malignancies. Anyone in this spectrum is prone, and then pregnancy and lactational women because of the increased demand in the body. Malnutrition. Malnutrition holds almost 80% of the stakes as far as vitamin deficiency is concerned. And again, like I said, because in our country, malnutrition is again a very crucial issue. So it basically is responsible for more than 90% of the vitamin deficiencies. Malnutrition can be either due to inadequate intake. Inadequate intake can be either because of malnutrition as a whole, or it can also be seen, inadequate intake can also be seen with the psychiatric illnesses like eating disorder patients, or patients who want to lose weight and fit into this frame of reference. So they also suffer from malnutrition, which leads to the illness, neuropsychiatric manifestations of vitamin deficiency. And people who are suffering from malabsorption syndromes also come under this, like celiac disease or the ones who have undergone bariatric surgeries. Now, these are the common neuropsychiatric manifestations. I think all of us are quite aware that it is highly unlikely that a person will be suffering from a specific vitamin deficiency at a time. If a person is suffering from a specific vitamin deficiency, we as clinicians always keep this thing in mind that they might be suffering from the other as well. So therefore, it becomes very difficult for us to rule out because of which vitamin deficiency what is being manifested, because almost all of them are concur. So if we'll be going through the subsequent slides, and we'll understand that these are certain manifestations which are common amongst all the vitamin deficiencies. First is the cognitive symptoms like memory loss, short-term or long-term, difficulty in concentrating or brain fog, cognitive decline or dementia-like symptoms. Then we have mood and behavioral changes like depression, anxiety, irritability or agitation, apathy or lack of motivation or psychosis. Then neurological symptoms like peripheral neuropathy, wherein patient will complain of numbness, tingling sensation in the lower limbs, burning sensation in the peripheries, ataxia, loss of coordination, weakness or fatigue, tremors, and even seizures. Sleep disturbances, insomnia or hypersomnia, altered sleep pattern. Psychiatric disorders like mania or bipolar-like symptoms, increased risk of neuropsychiatric disorders like schizophrenia and severe deficiencies, especially in the case of folate or B12. Although we don't have any data, any high proof data available with us, but studies are still going on. Now B12 and folate has become, again, it is another hot topic, and if the psychiatrists, researchers, and neurologists, they are looking forward to high potentials of these two vitamins. Surgery and motor changes, visual disturbances, like in case of vitamin A deficiency, hearing loss or tinnitus, in severe deficiencies and impaired reflexes. Developmental issues in children, intellectual disabilities, more so due to folate deficiency in utero and behavioral disorders, but the other vitamin deficiencies or malnutrition in whole is also responsible for developmental issues in children. Now, these are some key deficiencies and symptoms which are present with these vitamins. So, vitamin B1 is responsible for more profoundly responsible for confusion, memory impairment, Wernicke-Korsakoff syndrome. Vitamin B6 is responsible for depression, seizures, and irritability, although it is a very rare deficiency, but if manifests, it manifests such. Vitamin B12, which is quite common amongst Indian population, because most of them are vegetarian. So it causes cognitive decline, depression, psychosis, and neuropathy. Folate, depression, apathy, neural tube defects, because of which now the government of India has become very proactive and is providing folate and iron coverage to the antenatal women because of this reason. Vitamin D, depression, anxiety, and fatigue. Vitamin E, neuropathy, ataxia, cognitive decline. Vitamin C causes fatigue, irritability, and depression. With vitamin C, as we go further, I will tell about some specific features also. Then vitamin A, cognitive decline and visual impairment. Vitamin D deficiency, it happens to be the most well documented and well researched so far. So there was this systemic review and meta-analysis which was done in the year of 2014 and 16, which is given in the CTP as well, by Speeding and his colleague on vitamin D and depression. So after that, it was declared, or it was documented, that vitamin D does really leads to deficiency, leads to depression. So it causes persistent sadness, lack of interest and fatigue. So they did a study on people of the temperate region and realized that the people who had depression, almost all of them had the vitamin D deficiency as well. And their symptoms did improve on providing vitamin D supplementation. Cognitive decline, like it causes memory loss, confusion, increased dementia risk. Schizophrenia, hallucinations, delusion, cognitive dysfunction, although it is still not well documented and well researched, but they say it might also lead to schizophrenia. Seasonal affective disorder, depression during winter months, and autism spectrum disorder, developmental and behavioral changes in children, and multiple sclerosis, neurological deficit, fatigue, and motor issues. Vitamin B complex deficiency. Now, vitamin B complex deficiency, vitamin B1, which is thiamine, it causes memory loss and a very peculiar syndrome, which is known as Wernicke-Korsakoff syndrome and peripheral neuropathy. Vitamin B6 causes depression, seizure, irritability, confusion. B12 causes dementia, psychosis, neuropathy, and mood changes. Dementia and neuropathy are more profound. And folate, which is vitamin B9, causes depression, cognitive decline, apathy, and psychosis. And B3, niacin, it causes depression, psychosis, insomnia, and dementia. And we've read it in the past also that vitamin B3 deficiency causes pellagra, for which we had a mnemonic, which was 3Ds, which we will be referring to in the subsequent slides. And B2 and B5, although they're very rare, but they can also cause fatigue, irritability, general neurological dysfunction. Thiamine deficiency. Now, severe neurological and psychiatric disorder. We have read about all, it might cause dementia, it might cause irritability, it might cause confusion. But what really is a very severe outcome of thiamine deficiency is the Wernicke's encephalopathy, which is acute neurological symptom, which is characterized by confusion, ataxia, and ophthalmoplegia. And if Wernicke's is not corrected, it might lead to Korsakoff syndrome, which becomes a chronic condition, which is often followed by untreated Wernicke's encephalopathy, which causes severe memory deficit, both anterograde and retrograde, confabulations, wherein the patient will be fabricating stories and will have very distorted memories and will fill those memories with some fabricated information, and personality changes. And peripheral neuropathy is also seen with it, tingling, numbness, or burning sensation in the limb muscle weakness. This is important because this is something we will face in our day-to-day OPDs as we get the chronic alcoholic patients and alcoholic dependent patients. Then coming to the folate deficiency. Folate deficiency, it leads to, which is something, the folate deficiency effect in utero is something which is very extensively studied. So it leads to neural tube defects like spina bifida and anencephaly in fetus due to maternal folate deficiency, and behavioral and cognitive developmental delays in children who are born to the mothers with the folate deficiency. Niacin deficiency, pellagra. So pellagra is actually a syndrome which is characterized by the impact of the vitamin deficiency on various systemology. The dermatologically it leads to dermatitis, and gastrointestinal manifestation is that it leads to diarrhea, and neurological and psychiatric manifestation is of dementia. And systemically it causes fatigue and weakness. So in dermatitis, it has a very peculiar and a very pathognomonic rash, which is known as Casel's necklace, which is present around the neck, which is classic sign. And redness and scaling is seen. Thickening of the skin is also seen and resembling sunburn initially. In gastrointestinal, it leads to chronic diarrhea, abdominal pain, bloating, nausea, vomiting, glossitis, and stomatitis, which is again something which is seen with B12 deficiency as well. Neurological and psychiatric, it leads to dementia, which is and also leads to irritability, anxiety, apathy, depression, memory impairment, confusion, hallucinations or delusions. Advanced stages might even cause psychosis or dementia-like stages. Vitamin C deficiency. Vitamin C deficiency, severe deficiency syndrome symptoms lead to scurvy, and scurvy is characterized by these three manifestations: hypochondriasis, severe depression and suicidal ideations, and impaired problem solving and decision making. Now, suicidal ideation is something which I've only mentioned in this slide, whereas we've talked about a lot of vitamins before as well, because there was a case reported wherein they said that suicidal ideations were quite profoundly seen. And then when they got the vitamin or the biochemical assay done, so the patient had vitamin C deficiency. And after that, when it was treated, the patient recovered. But the patient was treated with antidepressants as well. Then vitamin A deficiency. In extreme cases, vitamin A deficiency can exacerbate neurological and psychiatric conditions through its effects on the immune system and the systemic health, leading to severe depression, cognitive decline, heightened vulnerability to infections, indirectly affecting mental health. That is why people with chronic illness are also prone to neuropsychiatric aspects of vitamin deficiency. Now, how will we manage if we come across a patient who has neuropsychiatric who's come to us with vitamin deficiency which has led to neuropsychiatric illness, or a patient already suffering from psychiatric illness who has vitamin deficiency? So first of all, we look out for the signs and symptoms of specific deficiencies. Although it is very unlikely that we will find a singular deficiency, patient will come to us with a cluster of various deficiencies, including deficiencies of minerals also. And we'll send for laboratory tests. We'll get the biochemical assays done specific to the signs and symptoms and specific to the deficiency that we are suspecting. And neuroimaging is something which can be done in case of vitamin B12 deficiency, but it is still not something which is pathognomonic of the illness. And we will call for dietary intervention. The first and the foremost is actually dietary intervention. We'll have to, because again, like I said, that the patient will never come to us with a singular deficiency. They will have a deficiency in cluster. They'll always be malnourished, mostly be malnourished. So we have to give them a dietary support and nutritional support. And along with that, we'll also call for vitamin supplementation, which is specific to the deficiency. After that, at the same time, simultaneously, we're supposed to treat the neuropsychiatric illness and the underlying cause, which is causing the deficiency and which is causing the neuropsychiatric illness as well. Now, vitamin B1 deficiency. Mostly in the alcoholic patient scenario, whenever we get a patient because the neuropsychiatric aspect will be, we'll get a patient with the Wernicke-Korsakoff syndrome. So this is how we are supposed to treat the patient as per the NICE guidelines. Prophylactic thiamine for low risk drinkers without neuropsychiatric complications and with an adequate diet. We'll order for oral thiamine supplementation of 300 mg daily during the assisted alcohol withdrawal and periods of continued alcohol intake. Then for patients who are being suspected for Wernicke's encephalopathy or the ones who have already established Wernicke's encephalopathy, we will have to give them 500 mg TDS thrice daily dosage for 3 to 5 days, followed by 250 mg of thrice daily dosage for further 3 to 5 days or longer. And then we will be subsequently shifting the patient to oral supplementation. Vitamin B12 deficiency. Patients will mostly come to us with the neurological manifestations more profoundly. So for that, oral supplementation is there of 1000 to 2000 micrograms per day. And it also comes in intramuscular and subcutaneous injection preparation as well, 1000 microgram once a week injection, which is given for first 1 to 2 months and then monthly for maintenance. And nasal sprays which are not currently present in the Indian market. Vitamin D deficiency. Vitamin D2 and D3, ergocalciferol and cholecalciferol, they are both effective. So initially we start with 50,000 international units weekly for first 6 to 8 weeks for severe deficiency. And then for maintenance, we shift to 1000 to 2000 international daily or based on the serum levels. For elderly patient, we should start them prophylactically on 1000 to 2000 international units a day to maintain their bone health as well as to prevent any cognitive decline. Folate deficiency, oral supplementation of 1 to 5 mg per day. This is actually supplemented free of cost by the government of India to the antenatal women also. Vitamin E deficiency, oral supplementation 4000 to 1000 international unit per day of alpha tocopherol. And for severe deficiency, you can go up to higher doses, but they have to be given under medical supervision. Niacin deficiency, oral supplementation of 300 mg per day in divided doses can be started with, and immediate release niacin or nicotinamide are commonly used. For vitamin A, the oral supplementation is of 1000 to 25,000, 10,000 to 25,000 daily for deficiency. It is basically ranges for the, it is with respect to the age of the child. We stick to this range. And IM and IV injections are also available in severe cases, especially in children or individuals with malabsorption. Now, along with that, obviously the patient will have a neuropsychiatric illness, so we'll have to treat that as well. So cognitive symptoms, we can go for cognitive rehabilitation or therapy and may help with memory and concentration problems. Psychiatric support, including CBT, can be beneficial, but only after the symptoms have reduced a little bit. Mood disorders, antidepressants or anxiolytics may be prescribed to manage depression, anxiety or irritability that result from vitamin deficiencies. Antidepressants like SSRIs or SNRIs may help in cases of mood disturbances, especially if in deficiency, has contributed to development of depressive symptoms. Motor and neurological symptoms, physical therapy, occupational therapy and neurorehabilitation may be necessary to help with ataxia, neuropathy and other motor dysfunction associated with vitamin deficiency. Speech therapy may also be helpful in the ones who have difficulty with speech or swallowing difficulties due to nerve damage. Summary. In the end, I would like to summarize by saying that this is a very new and a very hot topic, because obviously psychiatry as such is at the brim of progression, and now we are trying to understand the physical and the physiological and the biochemical aspects of the psychiatric illnesses, and vitamins are no less than that. So we have a long way to go in it. But as there has been a study, meta-analysis, and which has declared that vitamin D has a contribution to play in depression. In the coming years, the other vitamins will also come into play a role in the neuropsychiatric pathophysiology, and this will only help us with treating the patients. These are my references, and thank you.